welcome to the Medicine Matters Rheumatology podcast. I'm Claire Barnard. During the course of 2020, we have seen a number of rheumatology drugs being investigated for their potential to treat or prevent COVID-19. In the coming weeks, we will be bringing you interviews with experts involved in studies of some of these agents, including hydroxychloroquine, cytokine inhibitors, and JAK inhibitors. To introduce this podcast series, we are talking to Jinoos Yazdany. We discuss the rationale behind testing rheumatology drugs for COVID-19 and talk about what the potential implications are for rheumatology practice. Dr. Yazdany is a rheumatologist and professor of medicine at San Francisco General Hospital in the USA. She is vice chair of the COVID-19 Global Rheumatology Alliance and a member of the NIH COVID-19 Treatment Guideline Panel. First of all, Dr. Yazdany, could you tell me about the rationale behind evaluating rheumatology drugs for COVID-19?
So we've learned a lot about the SARS-CoV-2 infection over the last year. And what we've learned is that there's multiple phases of infection. Early in infection, we see viremia, and often people are either asymptomatic or have mild symptoms. And then later, in a subset of people, what we see is an aberrant immune response that can lead to very severe illness. And so really the rationale for using some of the powerful immunosuppressants that we use in rheumatology to treat COVID-19 is to decrease this later aberrant immune response and hyperinflammation. And, just a few words about this, sort of severe phase of illness. Some people have referred to it as resembling a cytokine storm. And by that, we mean we see elevated levels of cytokines. We see acute systemic inflammatory symptoms like fever. And really importantly, we start to see organ dysfunction. And, many organs in the body are involved, most significantly the lungs with acute respiratory distress syndrome. But we also see, renal disease, hepatic disease, and other organs. And so by using immunosuppression in the later phase of this disease, we hope to reduce the morbidity and mortality that comes with the organ damage caused by COVID-19.
Which agents have seen the most interest so far and why?
There are three main mechanisms that people have been interested in terms of using immunosuppression to treat COVID-19, and I'll just list them briefly. So first, we have steroids. These are some of the oldest immunosuppressing drugs that we use in rheumatology. They have broad immune suppressing effects. They work very quickly and they're inexpensive. And so therefore, they're very good candidates for using to treat this infection across the world. And we've learned from randomized controlled trials, most notably the recovery study, that steroids can reduce the morbidity and mortality from COVID-19, particularly in patients who have very severe illness or those who are mechanically ventilated. Next, there have been some rheumatology drugs that have been explored because they might have antiviral properties. The first in this class is hydroxychloroquine, which in the test tube has been demonstrated to have antiviral activity. However, when hydroxychloroquine was tested in randomized controlled trials, it really was not effective for any phase of the disease, including for pre-exposure prophylaxis, for early infections, or for late infections. And I think that data is pretty definitive at this point. We have, many randomized controlled trials that are negative. The other interesting drug that has some antiviral properties is baricitinib. And I'll talk about baricitinib more in just a minute. Next category is cytokine inhibitors. And here we have the IL-6 inhibitors, such as tocilizumab. We've observed that COVID-19 patients have an elevated level of IL-6 and that this correlates with greater mortality. And so there's been a lot of interest to see if, blocking IL-6 might improve recovery or reduce mortality. So far, the clinical trial data on IL-6 inhibitors is quite mixed. We have some very well done randomized controlled trials like the Back Bay study that was published in the New England Journal of Medicine, which were completely negative. But then we have a couple of other trials, including the Impactor trial, which was done in largely racial and ethnic minority groups, and then the REMCAP study, which seemed to show that there is a benefit for recovery. So I would say that the jury is still out on IL-6 inhibitors, and we really need to wait for the publication of some of the ongoing trials to see in which patients to use that drug. Next, we have the IL-1 inhibitors. These drugs have been of interest because we noticed that there's higher levels of IL-1 in patients with COVID-19, and that can be associated with hyperinflammation. So far, there's just been one randomized controlled trial that has become available looking at canakinumab for the treatment of COVID-19. And unfortunately, that trial did not reach its primary endpoint. There are other trials that are ongoing. And then finally, we have the JAK inhibitors, which are broad immunosuppressants that decrease immune activation. They can decrease cytokine levels such as IL-6. And interestingly, the very recently released ACT-2 study, which was the NIAID-sponsored study that first looked at remdesivir versus placebo, and then looked at the addition of baricitinib to remdesivir versus remdesivir alone, showed that baricitinib did slightly reduce the time for recovery, and soon there will be a trial comparing baricitinib to steroids, and I think we're eagerly awaiting that data.
So are there any concerns among rheumatologists about repurposing these agents for COVID-19?
Yes, and we have two main concerns. So the first concern is that rheumatologists have a healthy respect for the powerful immunosuppressants that we use. We know that they're associated with potential toxicity, and it is reasonable to be worried about using these drugs in critically ill patients. In the setting of chronic rheumatic diseases, we do see higher rates of infection in patients who are treated with drugs like steroids or IL-6 inhibitors, JAK inhibitors. However, extrapolation from our experience in chronic disease to critically ill COVID-19 patients, can be problematic. In fact, surprisingly, some of the randomized controlled trials actually show that people that were randomized to immunosuppressants like tocilizumab actually even had fewer infections than those who got placebo. And so, I think that the jury is still out on infections. One hypothesis is that if you actually reverse some of the aberrant immune response that we see in COVID-19 patients, you might actually reduce host susceptibility to infections. So I think, we really need to wait for more data. The second thing that we, have been really worried about in the rheumatology community has to do with supply chains. As the COVID-19 pandemic rages across the world, there have been, just an increased demand for a variety of the drugs that we use in rheumatology. And there's concern that this will decrease access to care for patients that need these drugs to control their disease. And in some cases, interruptions can even be life-threatening.
What advice should rheumatologists give to their patients if they're having issues with drug supply as a result of this repurposing?
I think the most important thing is to encourage patients to speak to their rheumatologist so that we can advocate for them. I find myself often having to call pharmacies or health plans to resolve issues around drug availability. Sometimes we've even just worked with our professional association, American College of Rheumatology, in order to advocate on a broader societal level to make sure that patients continue to have access to drugs. I think this was most dramatically illustrated during the time when hydroxychloroquine was being used to treat COVID-19, and we saw many shortages of the drugs and restrictions on its use. And even to the present day, some pharmacies are continuing to hold over some of the policies from earlier in the pandemic. For example, dispensing only a 10 or 14-day of supply to patients of hydroxychloroquine. And often, advocacy on the part of the physician to address some of those restrictions is successful.
So thinking about the clinical trials and other studies that are ongoing, how do you think rheumatologists should be involved in these to ensure the drugs are studied as safely and efficiently as possible?
We've learned a lot in this pandemic about the importance of well-done randomized controlled trials. I think the initial enthusiasm of hydroxychloroquine was based on a very poorly done study and led many people to get the drug inappropriately, and I think led to wasted resources in terms of randomized controlled trials in an area that ended up not being successful. We saw sort of a similar pattern with convalescent plasma. Over 70,000 people in the U.S. got it before we even knew whether it worked, and now there are some trials that suggest that it may not have a significant benefit. So I think the lesson here is that we really need to have an emergency research network at the national level that's capable of doing definitive randomized controlled trials quickly for pressing questions, whether those are associated with the pandemic or moving into the future. And as rheumatologists, I think we really should discourage the off-label use of medications for COVID-19 and instead encourage our patients and work with our colleagues to both design and encourage patients to enroll in well-done randomized controlled trials that'll get definitive answers to the public as efficiently and quickly as possible.
So thinking about the drug repurposing as a whole, what is the question that you're most interested to see the answer to in the future?
I think the thing that is an unexplored area for the treatment of COVID-19 is whether combination therapies are effective for the treatment of this disease. So, for example, we now have clinical trial data showing that steroids reduce mortality in severely ill patients. We also have randomized controlled data showing that baricitinib might reduce the time to recovery. So an outstanding question is whether combining these medications might actually improve outcomes, or whether it'll just be associated with more toxicity, including, I think, a very serious concern about infections. So I'm really looking forward to studies that look at how we might be able to combine therapies safely to treat this disease. In addition, it would be really wonderful if we could go from the immune phenotype of the patient that's based on molecular studies that we could quickly do in the clinical setting to actually choose the right therapy to dampen that aberrant immune response. I think we're still a ways away from that, and we'll see whether some of those studies might be completed, and perhaps there will be lessons learned from this experience that we can carry forward into the field of rheumatology even once this pandemic is over.
Thank you very much to Dr. Yazdany, and thank you for listening. This podcast was produced by Medwire News for Medicine Matters Rheumatology. Please subscribe for more podcasts on repurposing rheumatology drugs for COVID-19. Medicine Matters Rheumatology will also be covering the latest research and guidance on managing COVID-19 in patients with rheumatic diseases. Keep an eye on rheumatology.medicinematters.com for updates.